Yeah, thank you. Good evening to everyone. It's a pleasure for me to be present to talk you about my video. It's okay. How can I go on? Okay. This is a video of complex retinal detachment. I always started to trying to remove all the PVR, but sometimes is impossible, like in this case, because the retina was too much contracted and the PVR was not so fibrosis. So I decided to start performing a retinectomy. I first use for a good hemostasis diathermy to close all the blood vessels, and and then I start with the retinotomy. The retinotomy can be done by scissors or by cutter. In this case, I'm using a scissor because I think that with the scissor are less traumatic and more precise, and then I can go along the row of the diathermy. Some you have to remove all the blood, of course, to avoid the problem in the posterative period, and then go on again with the retinotomy. And sometimes, and of course, with the cutter, we can have more rapid and faster, and remove everything on the posterior edge of the retinotomy. I advise to for a good relaxation of the contraction, is important to extend the retinotomy into the normal retina, and then laser and the posterior, and at the end the exchange. The exchange can be done under air, perfluorocarbon air exchange, or a direct exchange under silicone oil. I prefer the direct exchange when the retinotomy is more than 2 quadrants to reduce the risk of retina slippage for an inadequate removal of a fluid at the edge of the retinotomy. So in conclusion, keep in mind for a complete hemostasis with the diathermy, and extend the retinotomy into the normal retina to have a better release of every contraction.
Thank you, Dr. Francesco, for this interesting topic, which is a real sight-saving procedure in complex cases. My question is about how to justify or to know the extent of your retinectomies, either on the anteroposterior length or the extent. Do you have a caliber or gauge to judge this during the surgery at the start of the procedure?
No. As I said, it's important to extend the retinotomy until the normal retina. During the surgery, I always try under perfluorocarbon to see if under perfluorocarbon I can make the retinal attach everywhere. If is enough, I go on with the fluid air exchange or a direct exchange. But if I notice some fluid around the edge of the retinotomy, I remove the perfluorocarbon and I extend a little bit more my retinotomy.
So you depend on the PFC to determine the extent of your retinectomy.
Yes.
Some people use air at the beginning of the surgery to highlight the areas of extreme contraction and shortening where the retina where the air will go underneath the retina. So either way can work.
This is another technique to see if you can release and to flatten the retina. I prefer use perfluorocarbon, but perform an exchange during the surgery to check if if you can flat completely the retina is another technique, of course.
Any questions?
Say 60 retinectomy because very most difficult it's keep the where age of retinectomy, because you know in basis certainly we have some of vitreal body and future we have in this PVR. So 360 retinectomy in this, like this case, maybe it's maybe more successful. It's easy to attach.
I didn't catch the beginning of your question.
I think the question is, would doing a 360 retinectomy
in this case
help relieving
like
more the PVR? Right.
Yeah.
That's the question.
Okay,
because
but in this
difficult
case
to keep age of retinectomy. If you have circumstance retinectomy, it's easy to keep.
PVR in the 360 degree, I'm agree with you, but in this case, the PVR was just in the inferior part of the retina. The superior part was completely attached and remained attached also after the surgery. So honestly, I don't think less is more. But in this case was complicated, but less is more, so in the complicated case. So I don't think it's a good idea to detach the retina where it's still attached, because you can have any other problem after the operation. So if the retina is attached without PVR, I don't think it's a good idea.
Yeah, I agree. It's psychologically maybe difficult to understand this retina attached, but in future sometimes we observe is attached at no PVR, then post-op maybe very early we are basis again PVR. But if you win, it's okay.
I let you know how it will be.
Thank you.
Yes, okay.
Yeah, when dealing with the case with the BVR and stiff retina like what we have in such cases, and you don't know how, what's the length of your, retinectomy, either 360 limited, we're trying our best not to go for 360 unless we are really need that. So starting with perfluorocarbon, look, if there is an area still not very well, attached, this is the area where you have to do your relaxing retinectomy. Sometimes it could be, with the perfluorocarbon could be attached. So when you go for air fluid exchange, again you will see either if the retina is stiff, the air getting underneath, this is the areas where you have to go back. So this is some tips that you can use it usually when you are doing retinectomy.
Yeah, I think perfluorocarbon is a very useful tool because you can flatten the retina, stabilize the posterior pole. For the hemostasis, so in this case, I always use perfluorocarbon.
Because sometimes might be there is no, that the BVR just only in the surface of the retina, thinking that you are really very great, but there are intra-retinal BVR. It's making the retina very stiff to the extent that it will give you an impression everything is all right, but actually it is shortening retina.
Yeah, you can keep it. Yeah. I think beautiful summary really of the PVR management from Dr. Hassan and also from Dr. Barca, and from the discussion as well we have. It's a bit of a balance. You want to remove what you need to. You want to get into healthy retina, but you don't want to extend the retinectomy so much because you're increasing the risk of more PVR. And you start by peeling posteriorly. You peel what you can, then after that you'll have to cut the retina, unless it's very peripheral and you can support it with a buckle or something like this. That's something you can do. So beautiful discussion. I think, thank you so much. That's perfect. One more question here from you, sir.
I just wanted to say that sometimes extending such a large circumferential, if you make some radial,
Yes.
it decreases the extent of your circumferential.
Yeah. Yeah, I think that's a really beautiful summary of management of PVR. We're sorted. Thank you so much.
Thank you.